A very good morning, ladies and gentlemen, colleagues. Thank you for joining us for this month's edition of the SK Dharmalingam lecture series. This is the 23rd installment of this series, which runs every month. It's named, of course, after the founder of the National Cancer Society of Malaysia, the first oncologist in Malaysia, Dr. SK Dharmalingam. And as we've seen over the series, what we do is every month we look at different aspects of cancer management, giving insights to fellow physicians on updates, innovations, new things which are happening in cancer, especially to colleagues not working in the hospital kind of setting, and especially to those in primary care. So this month, we're very pleased and honored to have with us Dr. Ganeshwara Durai Rajalingam. Dr. Ganeshwara is a pediatric and peripheral interventional radiologist and clinical radiologist at Hospital Kuala Lumpur and Hospital Tunku Azizah, which is with the Ministry of Health, Malaysia. Dr. Ganeshwara is speaking with us today on this very interesting topic of the work that he does and its scope in oncology. And so we have the title for this morning, which is Minimally Invasive, Maximally Effective, the multiplicity of roles of interventional radiology in oncology. So Doc, good morning. Thank you so much for joining us. Always a pleasure and honor to have you with us this morning.
Thank you so much. Thanks for that kind introduction. Firstly, I'd like to thank National Cancer Society for inviting me on today to spread a little bit of information about intervention radiology on the whole and its role in oncology specifically. It's been around for a while. Intervention radiology is definitely a growing field, especially in the field of oncology. So it'll be nice to share what's been around, what's evolving, and what's new in the field of oncology. Mind you, a 1 hour slot or even 2 hour slot is not enough to cover the whole breadth of what we do, but I'll try to keep each topic or each modality or sort of procedure 1-2 slides so I can cover as much as I can in a short period of time.
Absolutely. Thank you so much for that. And I think for our colleagues as well, this is more of a taster menu. So this is kind of to give you a little appetite and also for you to understand like all the different modalities that exist within the specialty and how you can reach across to interventional radiology for your patient's needs. I think that's kind of the angle that we're trying to get at. Doc, but before we start, we have this, I have this always burning question that I always ask everyone who comes on. Why radiology first? And then of course, second is, as if there's not enough headache, why interventional radiology? How come?
Well, to be honest, I was actually, what's the word? Motivated or surgical ammo that ready to cut up a patient or go that extra mile, getting up at 3 in the morning, being very exciting and all. Then I found that before you can do all that, you usually have to take that form down, if you all still remember, to see that radiologist and say, can you please confirm the diagnosis? So you then you come to the realization that imaging is probably integral part of not just surgical cases, but any field of medicine in its management of its patients. So that's when I did radiology. But then with time, your hands get itchy. As our professor, Dr. Murallitharan, Datuk Kanda will always say, once you've got your hands dirty, you'll always want to go back to that. And so intervention radiology was then a field where you could still get your hands dirty and still report some scans. So hence why intervention radiology.
Oh, right. Lovely. So, and you've had quite a wide kind of scope of experience as well, being attached to some other countries, including the UK, and then now you're here. And just out of curiosity, because you did mention that you're a pediatric interventional radiologist as well. So is there like kind of how many of you are there in this country? And, you know, is it a really busy load?
Right. So unfortunately, in Malaysia, we all come under sort of the umbrella of intervention radiology. Unlike in the UK or probably even the US, I'm not sure, but I'm guessing you sort of embark into that specific subspecialty of intervention radiology, be it intervention oncology, intervention neurointervention radiologist, peds intervention radiologist. Whereas here, we've got to sort of go through the whole gamut of intervention training, which includes a bit of neuro, a bit of peds, a bit of oncology, a bit of peripheral, a bit of vascular, and then sort of like in your final year, take that special interest further and reach out to that center that you feel would then be your field of choice. So yes, you know, prior to leaving for the final year of my training overseas, you know, I really didn't know there was such a field as pediatric intervention radiology. Let alone did I know that there was a scope for it. Well, luck had it that I was given the privilege to actually train in Great Ormond Street, which is not just a tertiary, but a quaternary pediatric center. And well, there they've got 2 intervention labs with 5 pediatric intervention consultants doing a variety of procedures. And that actually opened my eyes to, you know, how much peds has been sort of neglected, or pediatric intervention radiology has been neglected in this country. And it was a good eye opener. It's something, it's a way to sort of lay the groundwork for future pediatric intervention work in this country. At the moment, I think I'm probably the only one doing a pure, well, 80 to 90% pediatric work, but pediatric intervention work are being done in other parts of the country where they are intervention radiologists.
Right, excellent. So really, for many of us, I mean, like until I knew you were in the field, I didn't even know that we had pediatric interventional radiologists. So we're looking forward to you speaking to us today on this as well. So ladies and gentlemen, right before I turn the session over to Dr. Ganesh, I'm just going to kind of ask for a little bit of housekeeping as usual. Just please make sure that any and every question that you have, please just drop it so that Dr. Ganeshwara can kind of answer it right in between the session or right at the end of when we break, so that we can take any and all of your questions. So without further ado, Doc, please let me turn the stage over to you. It's entirely yours. Please go ahead.
Thank you. Hi, good morning. As Dr. Murali said earlier, my name is Dr. Ganeshwara, an intervention radiologist in Hospital Tunku, Azizah. It's a pediatric hospital, so we do mainly pediatric procedures, but as part of the whole GHKL complex, we also do a lot of other intervention, neurointervention, oncology intervention, and peripheral intervention as well. My topic today, as I mentioned earlier, is introduction of intervention radiology in oncology, a teaser to what we do and how we go about doing it. Firstly, let's get IR out of the way. What is intervention radiology? So IR practitioners are those who use medical imaging to guide minimally invasive surgical procedures, either to diagnose, treat, or cure many conditions. The imaging modalities that we use can include fluoroscopy, MRI, CT, and ultrasound. Many times we're called in for life-saving or life-altering procedures, be it to remove blood clots in brains, thrombectomy for strokes, drain infections in multiple parts of the body. It could be the liver, soft tissue, muscle, lungs, and also stop life-threatening bleeds. For example, GI bleeds, lower limb bleeds, solid tumors within the body post-trauma, for example. And as I mentioned, this could include trauma, internal hemorrhage, and problems during childbirth. Also, apart from the emergency procedures, we're also involved in more elective procedures. For example, tumor embolization, chemotherapy, opening blocked vessels, for example, lower limb plasties and stents, or treating painful uterine fibroids via uterine artery embolizations. Right, so let's now zero in on our role in in oncology. So as I mentioned earlier, IR in oncology is vast and it's wide. It's probably our biggest clients if you're comparing all the other limbs of interventional radiology. The scope is large and it's expanding, and it will becoming more integral in the treatment and management of oncology patients. Firstly, let's break it up into two, which is the diagnostic function of an IR in oncology, and then the therapeutic function of IR in oncology. In diagnostic, we're called upon to get a tissue biopsy, and therefore we use our multiple modalities, namely ultrasound and CT, to get tissues from organs that or lesions that we suspect to be malignant. This avoids the risk for a need for open surgery as much as possible. Not all, mind you, not all lesions can be biopsy or accessed, but if and when it can be, it then saves the patient a surgery to get a tissue biopsy. Secondly, fluid drainage. This can be diagnostic or therapeutic. You've got some pleural fusion somewhere, some ascitic fluid. Samples can be taken from the fluid, and of course, by removing these fluids, it will make the patient a lot more comfortable. Angiography, this is done under fluoroscopy with contrast and catheters and sheets and stuff like that. And we often do this to sometimes study vessels that may be infiltrated by tumors, which are suggested on CT scans, but we cannot be 100% clear. The reason for this is sometimes either to embolize the tumor before the surgeons go out and remove it, or to assess the blood vessels to see if those vessels are infiltrated and therefore need to be sacrificed, or it's not at all and therefore can be salvaged for the betterment of the patient. Also, fistulographies, for example, for tumors that have infiltrated bowel and bladder and have fistulas with skin surface, fistulograms are done to assess the size, the length, the tissues involved, the organs involved in such defects. So I'll just start with a case presentation or a short history, and then we'll just move on to how we do stuff. 62-year-old lady, Nali Paras, known case of endometrial carcinoma, underwent a TAPSO 1 year ago. Disease-free, however, in the last 1 month developed a vague abdominal pain, and a CT scan then was done to assess what's going on inside, and what was found to be multiple enlarged lesions in the right hemipelvis. So is it recurrence or not? How do we go about treating this? The oncologist will always require tissue sample, and that's when we are usually called in. So I'll just run through the CT scan of this patient. As you can see here, it's a abdominal pelvis CT scan. The base of lungs look pretty decent. The liver is homogeneous. You don't see any lesions in the liver. The left kidney looks nice. Coming down to the right kidney, you'll see that there is hydronephrosis. And she's got a nice variant here where she's got actually 2 ureters. So the duplex system, 1, 2, but they're both dilated. So, you know, there's something going wrong somewhere south. And as you enter the pelvis, you will see this very ill-defined looking lesion here, which sort of might have infiltrated the ureters, because you don't get to delineate it very well. And it's sitting somewhere in the region of the right hemipelvis, extending to the pelvis. So a CT guided biopsy was planned for this patient, and this is the image of a CT guided procedure. This is a biopsy needle. It's done under CT scan. So patient is in a supine position. The area is clean, and we then mark out where exactly we're going to insert our biopsy needle, and the trajectory of it is then guided by the CT scan images as we push the needle in. So just to show you that the trajectory that we went in, going straight down obviously is impossible because there's obviously bowel here, mesenteric vessels, and going in through this little window is also going to be tricky because you have the external iliac arteries, and behind it you have the internal iliac arteries, and if you're trying to come through the lateral side, you've got the pelvic bone. So the window is extremely small. This is usually done under sort of spot CT films. You push in the needle 1-2 cm, scan, make sure you're in the right plane, make sure you're not headed towards any structures that you don't want to hit. And once you're happy with your placement, then you plunge your biopsy needle in and take a sample. A week later, HP has come back as as metastatic adenocarcinoma. The stains have shown that it's a malignant tumor from the female genital tract origin, and therefore concluded to be a metastatic lesion. Moving on, drainages. Another simple case presentation. 70-year-old female presented with abdominal pain and distension for 3 months, unable to lie flat. She's obviously very, very uncomfortable now. On examination, she's got ascites. CT was done that showed a heterogeneous bilateral solid cystic adnexal mass and an anterior abdominal wall peritoneal caking. Running down her thorax TAP CT scan, you can see lungs are fairly all right, no mediastinal nodes, heart looks okay. Coming down, you can begin to start seeing this hypodense areas here, which are basically just ascitic fluid. It's extending right up to the diaphragm, as you can see. It's surrounding the liver, surrounding the bowel loops, surrounding the stomach. As you can see here, this ill-defined, irregular-looking thing is basically the peritoneal caking. And as you go further down, you will then see this abnormal adnexal mass, which is very heterogeneous with no clear margins with the uterus. The uterus also doesn't look normal, and you can conclude that this is some sort of a pelvic malignancy going on. We then went ahead to drain this patient. Of course, there is always need for tissue biopsy. But a patient like this, taking a biopsy at this point is not ideal because, as I said earlier, you'll have to go through a longer track to get to your target biopsy lesion. And the further it is from the skin margin, the harder it is. And when you do take a biopsy from a lesion, if there's fluid there, there's always risk of the lesion bleeding out, as opposed to when there's no fluid. Then as you take a biopsy, if you take a bite, the sort of peritoneal layers sort of serve as a tamponade and to stop any risk of bleeding. So therefore, we proceeded with a drain, an ultrasound guided drainage. This can be done on ultrasound. Ultrasound guided, needle in. Once you get access to the fluid, put a wire in, take the needle out, and put in a drainage catheter. On ultrasound, this is what it looks like. On the tube, this confirms that it's in the ascitic fluid. And externally, this is what it looks like. So it comes out from the skin, a little small tube, and this is then connected to a bag. It's a 10-15 minutes procedure. Drain the fluid, not to drain too much at each session, maybe 300 mils per hour, and replace fluids if need be. And within the day, the patient will be very comfortable. The drainage catheters come in various shapes and sizes, A being the most common one, as you can see here. That's why we call it the pigtail, because once you pull and anchor the catheter, it forms this little circle, which reminds us of a pigtail. It helps because with this pigtail, it increases the surface area of between the catheter and the fluid for maximal drainage, and it's also sort of an anchor. Tubes then come in various sizes, various shapes for different organs, different purposes. It can be used for drainage for abscesses, lymphatic fluid, multiple different uses for this catheter, and therefore the shapes and sizes also differ. These are the different shapes of the tip of the catheter. This is very good for putting drainage catheters in, say, a very thick pus collections where the holes are much bigger, and therefore it will be easier to drain out the fluid, as opposed to the pigtails where the holes are much smaller and therefore easier to get clogged. Again, the flip side is these catheters are less rigid and therefore slide in past your wire much easier, more comfortable for the patient as well. We often get this question from the ward calling us up saying, "Doctor, when can we remove this tube?" Or even the patient asking you, "Doctor, you put this tube in, it's dangling out of my body. How long does it need to be in?" So how long do we keep it in? It's usually kept in until the fluid is minimal. And how do you know that? When your drainage is about less than 10 mils a day, you know there's nothing much coming out. Why keep it in when there's a risk of infection? Or in an abscess collection, you keep it in until, well, the pus has cleared out. Nothing else except for maybe a bit of blood clots. So you know you're nearly done. Again, thirdly, when the residual collection is a lot smaller, so you can then send the patient down for an ultrasound maybe to assess if there's any more collection. If there's very little, pull it out. Do a chest X-ray if you want to see if your pleural fluid has been drained. Again, in an infection, in an abscess patient, when there's no fever, you know your tubes have done the trick, just remove it. And most importantly, if the patient has improved, she's not restless anymore, she can lie flat, you know it's time to remove the tube. Complications are rare, but that doesn't mean it doesn't happen. Sticking a tube in to any part of the body is, sticking anything into any part of the body is carries its own risk. Procedures are done under ultrasound or image guidance for a reason. Peritoneal drains is something that we usually let our MOs do, but you have to keep in mind there's this inferior epigastric artery that runs in the lower abdomen, and it's prone to bleed out if it's been punctured through while doing this procedure. Again, the drainage catheter is an external drainage device, and it's prone for infection over its insertion site, and that then can lead to sepsis, tube malposition where the tube is put in not within the most largest collection, and therefore it's ineffective. Again, we do this under imaging for a reason. There's always risk of bowel perforation, and mentioned earlier with sepsis, there's always risk of peritonitis, either localized around the puncture site or generalized if the infection has set in. Right. Again, zeroing down to oncology, most patients may have this long-standing ascites where patients come in, we put in a drain, patient is well, after about 3-4 days, you've drained out 3-4 liters, patient is well, he's walking around. You assess the patient, there's no more fluid, and you then pull the tube out. Unfortunately, in 2 weeks, 3 weeks, 4 weeks, she's back again, especially those with ovarian malignancies or lung cancers with pleural effusion, or well, patients with liver failure who come in with chronic ascites. They come back again, you know, you expose the abdomen, for example, and you see the multiple puncture marks that you've done. How do we sort of improve on this for the patient's sake and for your sake? Again, let's just go through. Malignant ascites is an abnormal collection of fluid in the peritoneal cavity. The peritoneal membrane involvement in some abdominal, extra-abdominal malignancies, changes in vascular permeability, lymphatic obstruction, hepatic congestion mentioned earlier, in hepatic metastasis, and exudative fluid secretion from tumor tissue play a role in pathophysiology of malignant ascites. The increased abdominal pressure may cause abdominal pain, as I mentioned earlier, as in the case of the patient earlier. Nausea, loss of appetite, the bowels are now all sort of partially compressed because of the fluid. Dyspnea because of the splinting of the diaphragm. Reduced mobility, it's heavy, patient doesn't want to move. cosmetic purposes, she can't even put her clothes on now. And of course, all this then leads to some psychological issues as well. And this then leads to, loss of mood, and sometimes loss of motivation for further treatment. So to work around this problem, what we've tried to move patient towards is something called a tunneled drainage catheter. A tunnel drainage catheters are similar in sense to our drainage catheters, but these catheters are larger in size, and they have a subcutaneous cell where the tube inserts into before entering either the ascitic fluid or the pleural cavity, with a special cuff. As you can see here, this white thing here is a cuff, which then reacts with the tunnel and forms sort of like a fibrotic structure, and therefore keeping the catheter in place. These catheters can last forever if it's not infected or blocked, and patients can go home with it, as opposed to the pigtail catheters. Usually we do not send the patients home with it because of risk of it getting infected or getting dislodged. These ones, patients can go home with it if the family and patient is motivated, knows basic sort of hygiene, catheter care. Patients can then go home with this catheter. This is sort of a more schematic diagram of what it looks like. As you can see here, this is the subcutaneous tunnel. So you puncture the peritoneum here, put in the fenestrated part of the catheter, make a tunnel, and finally this is where the catheter comes out from. It's made such a way, central abdomen, where the patient can easily reach for it, so that whenever fluid builds up in it, they can then connect it to a special connecting system to drain the fluid. Once it's drained, they can just easily disconnect that part and then use it again when and if the patient needs to. So this is what it looks. This is what goes into the patient. This is the cap which you attach to it when it's not in use. And if, say, patient becomes symptomatic, you can easily attach this part to the catheter and this part into the draining bag. So, for example, if patients are unwilling to do it, but they are motivated to use such devices, they can easily go to any GP nearby. It's an easy procedure done under aseptic technique. We can get, if it's not the Cancer Institute itself or their referring hospitals, any GPs down the road should be able to help you connect this device and drain the patient. The catheter itself is a bit more expensive, but if the patient, say, requires this drainage every 2-3 weeks, cumulatively, this is definitely a cheaper option. Benefits, as I mentioned, patient can manage the symptoms from the comfort of their own home if the family is motivated to. If not, a nearest clinic nearby, friendly GP there can obviously help out with them. Frees up a hospital bed from the point of view of a hospital admin. Prevents reintervention. Yes, it just takes one puncture and one tunnel, creation, which is all done in local anesthesia. It's one-time discomfort, as opposed to coming in every 2-3 weeks for reintervention, repuncture, running through the whole risk of it, of bowel injury, bleeding, infection, and stuff. And in the long run, it will save patient and the family lots of time and money. Complication rates, of course, there's no procedure without complications, but the overall rates are negligible. Infection rates is about 2.2% in pleural fusion patients. Occlusion is only about 3.7%. If it does get a pleural infected, then we have no choice but to remove it. But that is the same with our non-tunnel catheters as well. Up to date, there's no mortality caused by this procedure. So it's an option for patients that have malignant ascites. The caveat to that is the malignant ascites has to be simple ascites. Ascites or pleural fusions that are subdated are contraindicated for such procedures, because the tube will only drain the fluid in that sort of loculation and not the other locule. So simple ascites, it could be hemorrhagic, but still no, without any septations, yes, this catheter will work marvelously. Right. So moving on from diagnostic, I'm going to move on to sort of therapeutic, how intervention radiologists can help in the therapy side of patients. It's a whole long list here, and believe me, it's getting longer. Unfortunately, I can't go through all of them. I'll just go through some of the procedures we do, and maybe in the next series, we'll go through the rest. All right. The most important, I would say, paramount procedure, paramount importance for patients, oncology patients, is venous access. These patients have had granules or lines put in for first of all CT scan, then for their surgeries, and then for their chemotherapies, for blood transfusion, for hydration, and multiple other indications for putting in a line. And therefore, their venous access will and definitely get exceedingly difficult and tedious for us to achieve a good venous access. Therefore, something that is more permanent should be thought of for not only for the benefit of the patients, but also for the benefit of the clinicians, because as you know, setting a line sometimes can not only be traumatic for the patient, but for the doctor as well. So what are the options do we have? First of all, we'll start off with an implanted venous port, which basically is a chemoport. It's a surgically placed central venous catheter that is attached to a reservoir located under the skin. A non-tunnel central catheter could be a triple lumen, which is usually inserted directly into the subclavian, jugular, or femoral areas without tunneling. These are usually more short-term. It can last usually for a week. It's usually put in, say, prior to surgery, or patient comes in emergency. These catheters usually put in. They don't last very long, and therefore that should be kept in view when you're putting these catheters in. PICCs are catheters which are inserted peripherally, as it's mentioned in the name, peripherally inserted central catheters. These catheters are inserted either in the brachial or basilic veins, and it's a long catheter with its tip either in the SVC or sometimes in the cavo-atrial junction. These catheters can last anywhere between 6 weeks to 3 months. But if kept well, I know some patients have kept it for a year. It's extremely good because it can be given for chemotherapy. Chemotherapy can be used on these catheters. Patient can be blood transfusions can be done on these patients. Blood taking can be done on this using these catheters. And finally, it's a tunneled centrally inserted catheter. So these catheters are, if you know, very similar to what we use for dialysis patients, the perm cats. It's usually inserted either in the IJVs, EJVs, or the femoral arteries. And a small tunnel is then created under the skin for the catheter to exit from. It comes in the cuff and non-cuff forms. The cuffed forms are usually the more permanent ones, which can stay in for about 2 years. The reason for the small cuff is to promote tissue growth to adhere to the catheter and therefore reduce the risk of it slipping out. Okay, so choosing the correct venous access, as I mentioned earlier, it's not just as simple as saying, okay, let's just put something in. You need to talk to the patient, explain why you're choosing such catheter. You need to know why you're putting the catheter in, what size, where, and how long these catheters need to stay in. Priority obviously is given to minimize the risk of infection. As you know, these catheters work well without infection. When infection sets in, you got to take it out, causes thrombosis, and then you might lose that line, that vein for further venous access. So therefore, we try to avoid femoral vein as much as possible. The groin isn't the most hygienic area, and therefore that's our last option. In some cases, consideration may include availability of assistance from caregivers. For example, a family should be motivated enough to know how to use it, and therefore, and hygiene also. No point putting a catheter in a patient that goes to poor social support system where these catheters are going to get infected. Again, patients who've had, say, bilateral mastectomies, the wounds are not healing. You really don't want to be putting Chemoport in such cases, which may then lead to wound breakdown, infection, and stuff like that. Again, engage with your patient to ask them what their preference is. For example, a patient who likes to play or swim, anything that's external, such as a PICC, may not be the best thing. At this point, I'd like to tell you a little story of a patient I met in the UK. It's a little boy who needed venous access. He was transferred in from another hospital. The previous hospital had actually put in a tunneled Hickman, which is a tunnel catheter, and for longer term and for hygiene purposes and longevity of catheters, we decided to put in a port for the patient. Therefore, it's concealed. There's no sort of patient can then move around, run around. There's no risk of sweat or infection setting in. However, after putting the port in, patient became very restless. Was very depressed and didn't want to engage with the hospital staff. He was then sent to the psychologist, who then ascertained the history that the patient didn't want any. He was very distressed that there was an implanted device in his body, despite explaining to him the benefits of it. And this is a child, mind you. Despite mentioning that you don't have this catheter dangling out, there's no risk of it sort of being pulled out and stuff like that. He just didn't want this implanted device in him. And therefore, the catheter was then removed under GA. Again, it's a pediatric age group, so it was then removed and converted back to a tunnel catheter. And this is a good example to highlight that it's always good to engage with the patient. The choice of catheter might not be right or not optimum for the procedure or for the condition, but still it's up to the patient to decide. So you've got to walk around that when you choose your devices. I'll just go into chemoports because in oncology patients, that's usually what we put in. What is a chemoport? It's a small implantable reservoir with a thin silicone tube that attaches to a vein. The main advantage mentioned earlier, it's a way of getting medications into the bloodstream without multiple needle pricks. Okay, unlike IV catheters, which need to be reinserted all the time, the port can remain in as long as possible. Some are in for months, even years. And when it's no longer needed, it can be easily removed with a simple outpatient procedure. The other benefits, again, the port is usually prepared in a sterile technique. Even when instituting any chemotherapy and stuff like that, it's usually done in a very sterile technique, and therefore it reduces the risk of infection. It can be used to deliver fluids, drawing bloods. It can be used, the power ports, which are compatible with CT scans and PET scans, can also be used to inject contrast. Again, because it's going through the port, it reduces the risk of a medication being in contact with skin, reducing the risk of skin irritation. And the port can be used over multiple days during one cycle of chemo. This is an example of ports. They're different sizes. Again, choose your size wisely. The pediatric ports are small, 5 French, 4 French. Then there are the bigger ones, which are 6 French, 7 French, and some that go up to 9 French. The bigger ports obviously give you the benefit of using larger volume sometimes. The smaller parts obviously are better and more aesthetically pleasing. However, again, choosing ports are also very important. Don't choose a big port for someone who's, thin, cachexic, or in a pediatric age group where there's very little subcutaneous cover. That will lead to the risk of the skin breaking out over the tube. Again, don't use a small, cute little port for a patient who is on the bigger size. It might look aesthetic pleasing. Patients say, "Oh, I don't see anything," but it will then be difficult for you to then identify the probe. So how you've got to use the ports are by holding it between your fingers and puncturing the septum area. The smaller the pot is, the smaller the septum is, and the harder to find. And those patients with a very thick subcutaneous tissue, this will prove very difficult. So if you don't want your oncology nurses to curse you, use the proper size pot for the proper size patient. Just going through the anatomy of the pot, it's usually made out of titanium and POM. It's safe for MRI use. They weigh anywhere from about 2.9 kgs to 10 kgs. The septum, which again I mentioned earlier, is this black thing, is where your hypodermic needle is used to puncture in, and it usually allows for about 1,000 punctures. So that should be enough. That should be well more than enough times that the pot needs to be used. The reservoir, which is this space right underneath the septum, is less than 1 ml. You don't want too much of this because if, say, flushing is not done very well, you might have some blood or medication sort of left behind, and that will then lead to a focus of infection. Again, pots are nowadays made CT scan compatible, and therefore you can use it for injectors, power injectors during your chemopots, CT scan studies. Where do we put the chemopots? It can either be put in your internal jugular vein, the subclavian vein, the axillary vein, and now we're even going towards the cephalic. The small pots can be even put on your arm. Again, with the pots in the arm, the pots are usually smaller. The one most centrally, you can use the bigger pots. And if the upper extremity vessels are not suitable for chemopot placement, then a femoral pot is also an option. Again, we try to avoid the femoral access because of the risk of infections. Again, as I mentioned earlier, no procedure is without its pros and cons. The disadvantage of the pot is the risk of infection. Of course, it's much less than say the PICC or the non-implantable devices, but the risk is there. When it gets infected, antibiotics can be administered, but if that doesn't work, then the pot needs to come out. There's also a risk of thrombosis. The catheter with any foreign body within your body, within your vessels, are prone to some sort of thrombosis. Chemo drugs that go through it, if not flushed well, may then develop blood clots within the catheter and will block the whole catheter off. Of course, there are ways to go around it. Blockages can be unblocked if picked up early, and if the clot's burden is not too big, via some infusion of some heparin. There are also other disadvantages where the pot and the tube come disconnected in the skin, and they're deemed not to be used. There are also pots where, if not stitched in properly, can flip. Therefore, the septum now, instead of facing up, faces your thoracic cage, and therefore it cannot be used. Also, other disadvantages or more aesthetic factors. Some patients won't want a scar on their chest wall. Its scar isn't very big, maximum 1 to 2 cm, but if they're particular, that might be of concern to patients. Other procedural risks while putting in the pot, such as bleeding, infection, pneumothorax, are there. Again, we do this with ultrasound, with fluoroscopy, to reduce the risk of any of these happening. Avoiding, as I mentioned earlier, avoiding the complications. It is very, very important to flush the catheters with either antibiotics or heparin solution to avoid infections or thrombosis. Any local redness over the skin, tenderness over the skin, needs to be treated early, as soon as possible, either with local or oral or IV antibiotics, to avoid the need to remove the catheter. GPs in clinics as well, if patient has come in and says, doctor, I've got this spot, there's some redness, treat it early if you can. Some might come up to you and say, I haven't used the pot in months, worried it might get blocked. Simple heparin pump just to unblock the catheter can help as well. So how do we insert the pot? I'll start off with my smallest patient ever, which is an 8-week-old baby boy. Weight is about 5.6 kg. Was diagnosed with bilateral congenital retinoblastoma. Mom also had retinoblastoma at the age of 2 and had an ablation done. So this baby obviously required some systemic chemotherapy and therefore was sent to us for a Chemoport insertion. This is the little fella. It's obviously done under general anesthesia. The patient is usually in a supine position. The neck is slightly extended towards where you want to put it in. Shoulder roll is also put underneath to sort of open up the neck region to get a better exposure to your surgical space. This is what we aim for. We use an ultrasound guidance to puncture the internal jugular vein. This is the carotid artery, this is internal jugular vein. Under aseptic tank, under ultrasound guidance, needle is then used to puncture the vessel. Just a little video of it. You can see here the needle going in, hitting the vessel. Once you get some backflow, then you put in your wire. So you got some backflow coming in here, put in your wire. And then once you get your wire in, you can take out the needle, and now we've got access to your internal jugular vein, wire in the SVC, and sometimes we push it into the IVC just to be safe. This is me making the port, creating a chest wall port. So this is the wire that's in, secured with a small sheath. This is us opening up the port, opening up the skin and the subcutaneous layer. And this is me just putting the port in to check whether it's of adequate size. It's got to fit snugly in the subcutaneous layer or right below the subcutaneous layer in peds, and to make sure that the skin over it is not taut and there's enough subcutaneous tissue coverage to avoid any wound breakdown. Once I'm done, the skin is closed in layers, and I top it off with a bit of glue over the neck puncture site as well as the skin. And this is the X-ray post chest Chemoport insertion. Right, moving on from chemopots, something that's more exciting, interventions in gallbladder, biliary system, and pancreatic malignancies. So percutaneous drainage is another procedure that we do quite commonly. It's when there is some cholestasis, buildup of bile within the liver, be it due to stone, in the case of malignancy, due to either pancreatic carcinoma that's blocking it down below, or a liver HCC where it's blocking the hila, or a gallbladder tumor that is sort of impeding the common bile duct. This cholestasis itself can be a focus of infection. Again, anything that stays sitting for a long time is a focus of infection. Hyperbilirubinemia can damage renal function and should be drained percutaneously or endoscopically as soon as possible to avoid any further complications. As I mentioned, biliary strictures, either intrinsic or extrinsic, malignant or benign. Indications again, bile drainage in obstructive jaundice or septic cholangitis, secondary benign or malignant strictures. It can be either a palliative procedure or pre-op procedure to decompress the system. Treatment of bile leakages, patient would have gone for surgery, either for gallbladder surgery or hepatectomy, and they might have nicked the bile duct, and there's now bile developing in the peritoneum. Biliary diversion is then asked from us to put in a PTPD. Also, there's ways of biopsying through your through your PTPD tract to take biopsies of intraluminal lesions, and ancillary therapy, for example, for removal of stents, internal radiation, stricture dilation, and stent insertion. Contraindications, patients with bleeding diathesis. It's always important to correct these bleeding diathesis, bleeding disorders before doing this procedure. Relative contraindication, again, relative sepsis, overt sepsis. Sometimes it's caused by this biliary stasis, so try and control it, manage it before doing the procedure. Hypervascular tumors, again, sometimes you have these real vascular tumors obstructing the biliary system. If you still need to do it, be mindful, try and choose a tract that does not go through these vascular lesions. If there are multiple intrahepatic metastases, they're just blocking it everywhere. chances are by putting a tube in, you might just drain one part, but not solve the whole, the cholestasis on the whole. Large ascites, again, as mentioned earlier, with the biopsy patient, with large ascites, there's no tamponade. As you put in the needle, everything is moving. Your wires will get kinked. Your tube will easily slip out, and therefore it is always advised to drain the ascites as much as possible before putting in a tube. This is a schematic diagram of the procedure. A wire, first the puncture is done. A wire is then threaded into the common bile duct. Further, if you can, obviously, if you can get into the duodenum, even better. And then a drainage catheter is then threaded over the wire and parked in the gallbladder, common bile duct, or in the duodenum. Another example of what our pigtail looks like. Right. This is fluoroscopy images. Again, under ultrasound guidance first. Then a puncture needle is introduced into intrahepatic duct. Once you're in the duct, you confirm it with injecting some contrast so that you know you're in a duct and not a vessel. You know, on ultrasound, any tubular structure all looks the same. So confirm that you're in the duct. Inject a contrast, delinate it, push a wire in, get the wire as far as you go in, and then either put in a sheath or put in a drainage catheter. Yeah, so a sheath is then put in, and then that's dilated, and finally drainage catheter is put in as far as you can. Notice here, you just see dilated ducts. You do not see, you see a bit of the common bile duct, but you don't see the rest of it. So it's obviously very dilated and very stenosed system. Usually in a system like this, patient not very stable, septic. We just put this in to decompress the system. Once the patient is better, then you may go in for further procedures. This is a CT scan of a patient with a hilar cholangiocarcinoma. You can see the ducts are extremely dilated. And this is with the tube in. This is the pigtail drain all the way in as far as you can. The ducts are still dilated, you can see, and there's also contrast within the gallbladder. If you make out here, this contrast here, then there's sort of opacity here. You don't see much contrast here, and then some more contrast within the distal common bile duct. So you know that this area is either compressed by the tumor or it has infiltrated the tumor. Sometimes the right and left may not be connected. You know, we got a tumor sitting just after the common bile duct branches into two, and sometimes therefore you need to put the catheters on both sides. Or if you cannot drain on one side, send this catheter in from the left and put it here and let it drain from the right and left. What are the disadvantages of leaving a catheter out? So with the other catheters, other drainages I mentioned earlier, like ascites and pleural drain, the patient has the discomfort of this bag dangling out. Some patients don't like it. There's some patients are prone to dislodging it because they accidentally pull on the catheter. Secondly, as bile salts are lost to the bag, patients then develop dehydration, electrolyte imbalance, malaise, and anorexia. As I mentioned earlier, if you can get your catheter into the duodenum, that is much better, and therefore these catheters can be clamped on the skin, so you don't have to sambung it to a bag, just clamped, and therefore you let the bile drain downwards into the duodenum like how it should normally happen. Of course, the risk is the catheter is now within the duodenum. There's always risk of cholangitis developing from debris in your gut going up to cause ascending cholangitis or pancreatitis. What is an external drain? So this is an external drain. Catheter is in all the way into the common bile duct. You can't get into the duodenum. Never mind. When you start off, just let it drain externally. But if you manage to, you've put the catheter all the way in with the tip here. You've got some drainage holes here. You've clamped the outside, and therefore the bile then drains through the catheter into the duodenum. Complications of PTBD, as I mentioned earlier, cholangitis, sepsis, bile peritonitis, where you puncture the liver. If there's a bit of fluid, a bit of ascites, there's always a possibility of bile leaking into the peritoneum, which can get infected. Hemoperitoneum, if you nicked a vessel as you go pushing your needle in, that can lead to hemorrhage. Hemophilia, blood in your bile ducts due to traumatic puncture. If you've gone through an artery and vein, there's always risk of a fistula developing, hepatic artery aneurysms. If you've gone through the pleura to get to the liver, there's risk of pneumothorax, hemothorax, liver laceration if the puncture has gone wrong, and risk of allergic reaction to contrast media. So after putting the drainage catheters in, what do we do next? How else can we help the patient? The tubes that are in, as I mentioned earlier, drainage catheters can only last 6 weeks, and it's prone to infection. It's external, it's not comfortable for the patient. It can get dislodged, malpositioned, and infected. What is the, if it can be settled with a plastic stent, a plastic can be put in. However, with oncology patients, these obstructions may be long-standing, and therefore plastic stent is not good enough. Therefore, metallic stent is probably a better option. It has a larger diameter, which is about 10 mm, as opposed to the plastic stents. Patency is very good. Again, it's a metallic stent, so it's not as easily compressed by, say, a tumor or a stone. It doesn't require external drain anymore. And you sometimes can put more than one stent depending on the need. This is how it looks like. This is the usual one we use. It's a self-expandable nitinol biliary stent. Sometimes you might need to use covered ones, especially in the cases where there are leaking or ruptured biliary tracts and you need a covered stent, then you can use this. But most, if it's obstructions, a bare metal stent is all that we need. This is how we deploy it. It's like a payong actually. It comes, this sheath is over it. And once you're in the right place, you just pull it back to expose the stent. It's very malleable in the sense that it will sit in accordance to the size or the shape of the CBD. Therefore, it's atraumatic in a way. This is an example of biliary stent placement. You can see the catheter in here, very narrow, don't see actually the rest of the CBD. And after you've inserted a drainage catheter followed by stent placement, you can see these are the struts of the stent. These two black markers here going all the way down here. And once you put it in, there's good flow into the duodenum. Again, as mentioned earlier, if there's a block on the right and left after the highlight, you might then need to put in 2 stents, and it can be easily done. Why in this way, and a stent next to each other. Either a stent within stent or next to each other works fine. Strictures, sometimes the stents then become occluded as the tumor may get bigger, stent narrowing may happen. This can be easily dealt with by putting in a balloon and ballooning the stent. Just if that doesn't work, putting a stent in stent is also another option. Moving on, IVC filters. So IVC filters are devices that we put in the IVC, obviously, to avoid or to avoid pulmonary embolisms, or to avoid further clot burden into the pulmonary system. Why is it useful? I'll go to it in a while. It's a device that it's divided into two, either permanent filters or non-permanent filters. We are now going away from permanent placement of filters and more of a temporary or non-permanent filters. These filters are exceedingly getting more important as the diagnosis of DVT is becoming more prevalent, and cases that are getting more complicated or complex. It is important to know that these filters itself, although the function of these filters is to avoid PE, anything, as I mentioned earlier, anything that's foreign in our body, in our vessels, are a nidus for thrombosis. So filters, although they are there to avoid PEs, as and when it's possible, please do remove it. And you don't want any filters to be kept in longer than its use by date. Okay, although some patients may need long-term, and therefore you might then have to leave it in. If a patient is not contraindicated for, say, some anticoagulate therapy, these filters should be removed. So indications for filters, relative indications should be iliocaval DVTs, large floating DVTs, massive PEs, thrombolysis for DVT. So in the treatment of thrombolysis, these filters are usually put in. Those with DVT with limited cardiopulmonary reserve, therefore even the smallest thrombus might cause severe PE. VT in pregnancy, debatable, and also VT in organ transplant patients where anticoagulations may be contraindicated. Also, there's a group of patients that may need it where they don't have history of DVT, but high risk of DVT, especially in patients with trauma, high risk orthopedic procedures, surgical procedures, and medical conditions. Coming to oncology, we find a lot of patients with pelvic malignancies, especially at increased risk of DVT. Sometimes it's actually an incidental finding. They come in, again, a lot of patients, abdominal distension, ascites, drain the ascites, do a CT scan, find this pelvic mass, and incidentally, we find some clots in the lower limbs. So what happens is, going back to the scenario, so patient then is started on some anticoagulants. It's working. There's no progression of clots. However, patient is then planned for surgery, and therefore the anticoagulants need to be stopped during surgery, and therefore the IVC filter sort of serves as a bridge between the time of no anticoagulation until when they can recommence anticoagulation. So it's an integral part of management of oncology patients, and be very mindful that PE DVT is, although it may seem asymptomatic in some patients, it can cause PE, which is very detrimental. So this is an example of IVC filter. How we do it, it's done under local anesthesia. Usually the patient's on a Clexane, so it's the dose before, the night before the procedure, the dose is omitted. It's an IJ, internal jugular vein puncture, and then we put in a sheath and we deploy a filter. The filter comes in various shapes and sizes, different shapes, but all sort of having the same function. It looks like sort of like a cage kind of thing, and that's what it's meant to. It's meant to catch clots that may be flying upwards. The small, tiny ones may escape, but the big, chunky ones are then caught in this cage. This is a venogram before we deploy our filters. As you can see here, these are filling defects caused by clots. Otherwise, the vessel is very smooth, nicely opacified, but this clots here. So be mindful to always put the filter above the clots. Don't put it below the clots. It'll, defeats the purpose. And also be very mindful where your renal veins and hepatic veins are when you deploy your filter, because you don't want to impede the flow of the renal veins, because this may then lead to renal vein thrombosis. As I mentioned earlier, there are various shapes and sizes of these filters. All in all, it just looks like either a pyome or some sort of a net to catch thrombus. Although they may come in various shapes and sizes, they have one thing in common, which are these little struts, these little hooks at the end of their prongs, which are used to then anchor onto the IVC wall. I'll come to the good and bad of it in a while. Well, the good is it holds it in place, avoids the filter from being dislodged, especially if patients are going in for surgery. While manipulating the manipulation during surgery, there might be a risk of the IVC filter being dislodged, but these little claws on the end hold it in place. And as I said earlier, anything that goes in should be taken out, and again, that comes to us to remove the filter. Same thing, neck IJV puncture, internal jugular vein puncture, with fluoroscopy in our sheath. This is the sheath. As you can see, this black sheath. It's very much, we feel like a cowboy because it's putting in a snare to try and snare this little hook. Most filters come with a little hook where you snare it, catch it, and then you pull it within the sheath. So this is the sheath tip, and this is the filter within the sheath. It's like sort of closing an umbrella from the top. So imagine an umbrella with a hook on the top. You grab it and then you sort of push it down. This is another case where the filters can be removed either from the top or bottom. This is obviously from the femoral approach, as you can see here, the femoral head. This filter has a hook at the bottom. Again, you hook it in, push your sheet over, and that collapses the filter. And this is a very important image of what your catch of the day looks like. So once you remove the filter, it's always good to examine the filter to make sure that all the prongs are there and you haven't left one kaki inside. And also it's good to see how much the filter, how good the filter functioned, as in how much clots it has caught. And more importantly, to know that if you leave this even longer, this thing is going to be a source of thrombosis itself. So some of these clots might be the ones that were wandering, embolized from somewhere and moving upwards, but some of these thrombosis might have developed around the filter itself. And therefore, I stress again and again, if a filter can be removed, remove it. If you see this patient or you've done an X-ray and you find a filter in a patient in a GP setting or anywhere, please remind them, hey, try and get this out. This is an example of why a filter shouldn't be left in for too long. As you can see here, this is the IVC. And so for patients who've had filters in for a long time, we always insist on a CT scan to see what's happening, to see how the filter anatomy is. And you can see here that the filter has actually, the prongs have actually cut through the vessel wall and is sitting outside. There's even one sort of prong butting the aorta. And if you now try and attempt to pull this filter out, there's always risk of rupturing the IVC wall. So I stress again, as soon as you don't need the filter, please remove it. Right. Okay, so moving on to my last big topic of intervention, radiology and oncology, and probably the most exciting is cancer treatment itself. So we've done diagnosis, we've done management, and now we're moving into the treatment itself. It's a field that is growing. It started with probably just the liver, but it's now moved on to actually mode of treatment for multiple other organs as well. And I'm sure at the time of this presentation, there are new procedures that I'm still not aware of. Okay, so what is cancer treatment in IR? Minimally invasive image-guided cancer treatment as an adjunct or an alternative to surgery are increasingly being used in the management of malignancy. Delineation of the arterial supply of a solid tumor by contrast-enhanced CT or MRI facilitates devascularization of neoplastic tissue by transcatheter embolization. Previously, bland mechanical occlusions can be achieved by gel foam. Gel foam is just like sort of like sponge tissue. PVA, blood clots, different occlusive devices, and coils or particles have been used to block off the tumor bed. What it does is we inject these lesions, these particles or devices to the vessel supplying the tumor, and in the aim to block off the supply to the tumor in the hope that this will then cause the tumor to shrink or regress. And this is then either followed by the surgeons removing it or not doing that at all. We then evolved into transarterial chemoembolization, where not only do we block these vessels, we actually lace the particulate that we push in with chemo drugs. Therefore, not only blocking these vessels, but simultaneously administering chemo drugs directly to the tumor, and this reduces the risk of systemic, reduces the dose of chemo drugs that we need, and targeting it towards where we actually want the tumor drugs to go to. Just recapping, so what we usually do, it's a femoral puncture into the hepatic, into the femoral artery. Under fluoroscopy guidance, the catheter is then guided into the hepatic artery, and then it's the vessel supplying the tumor is super selectively cannulated, and the chemo drugs are then mixed with something called lepiodol, which is sort of a contrast agent. So when you inject the drugs, you can visualize where the drugs are going. And once we've injected as much drug as we can, we then embolize it with either gel foam or some particles. As I mentioned earlier, advantage of a TACE over systemic therapy is it is targeted, allowing for higher local concentration of drugs with lower systemic dose and therefore less systemic side effects. This is what it looks like. You can see here a catheter within the main hepatic artery. And within this, we usually use a smaller microcatheter to go into the smaller vessels. The medication and occlusive agents are then injected. This is the image post the TACE. As you can see here, on this run, you don't see much filling of contrast into the tumor blush itself, and that means we've actually blocked off quite a bit. Also, this is a good example of a TACE procedure. The challenges when we do a procedure, as you can see here, we inject this this vessel with contrast, and you see this part of the tumor lighting up, but this part is not really lit up, and therefore you know that this tumor is then supplied by another vessel, which you now need to go and hunt and try to embolize it as much as possible. So this is TACE, where the chemo drugs are administered super selectively, followed by embolization. So it's a transarterial chemo embolization. Some fractures where only chemo drugs can be administered and embolizations are not done, because these vessels are also the main supply for the surrounding structures. With liver, this is possible because, as you know, the main supply to the liver is by the portal system, and therefore, even if you block this off, new vessels may develop from the branch of the hepatic artery, but the main supply is still from the portal vein. So, example of a chemo infusion is in the treatment for retinoblastoma. So, retinoblastoma is the cancer of the eye. As I mentioned earlier, one of my first my Chemoport patient. It's the most common intraocular malignancy in children. The origin is from retinal cells of the neural layer. There's no known geographic, racial, or sexual sex predilection. Most common presentation is white pupillary reflex, leukocoria. Other symptoms may include strabismus and decreased vision. In advanced diseases, the iris color changes. There's an enlarged globe, exophthalmos, and orbital inflammation. This is obviously late signs, and these late signs will usually lead to enucleation. This is a MRI sequence, DWI ADC sequence of retinoblastoma. You can see restricted flow within the tumor. It lights up, and you can see it's quite obvious. It's usually in the posterior chamber and needs further treatment. Intraarterial chemotherapy is an option for intraocular retinoblastoma. It used to be a salvage therapy, but because it has shown to be quite promising, it's actually now used as maybe not first line, but second line treatment for retinoblastoma. It refers to a super selective intraarterial chemotherapy to the eye that involves super selective cannulation of the ophthalmic artery. A principal motivating factor is to deliver increased local concentration, as mentioned earlier, to the eye without excessive systemic toxicity, which is not possible with systemic administration. So this technique isn't very old. In 2004, it started with the Japanese. What they did is they put in a catheter again, then the catheters have obviously evolved, but those days they didn't have such fine catheters. So the catheter was, this is called a balloon catheter, where it's advanced above the ophthalmic artery, which is this, and then inflated in such a way, and the medication is then infused. So because of the balloon being inflated here, the medications has no choice but is forced into the ophthalmic artery. However, this obviously increases the risk of the child getting a stroke. I mean, if you've basically blocked off the vessel that supplies the brain, be it for 4 or 5 minutes, but still the risk of a stroke is there. And therefore, again, balancing the pros and cons, the Japanese decided to do this. Fast forward 4 years later, fast forward catheter technology, fast forward radiation technology and imaging, we now have a more novel approach where the catheter is advanced into the ophthalmic artery. Mind you, these are done for kids as young as 8 months or even younger. So can you imagine what the size of these catheters are? If and when you do successfully cannulate the ophthalmic artery, then a chemo infusion is then done. Just to give you a rough idea of how it evolved, the Japanese found that melphalan, which is a single agent chemotherapy, was effective for IAC. However, with time and outcomes with IAC, Abramson added carboplatin and topotecan as a triple drug regime for treatment for IAC for retinoblastoma, and it's shown to be very effective. This is one of our patients. This is a patient, I think must be about 1 year old. How we do this, obviously under general anesthesia. A small sheath is inserted into the femoral artery. Vertebral catheter is advanced under fluoroscopy guidance into the internal iliac artery. So you can see this is the internal iliac artery. Internal carotid artery. Sorry, I'm getting confused here. And this is the catheter at the proximal internal carotid artery. And this then delineates the vessels to the brain and also the little vessel that goes into the ophthalmic artery. We make sure that the rest of the brain looks fine before super selectively cannulating the vessel. And this is the little micro catheter. So you can see this is the bigger catheter and this smaller catheter. Mind you, this is a 4 French catheter, which is about 0.25 cm. And this is another little one sitting inside the ophthalmic artery, showing you a nice enhancement of the globe. Once your catheter is parked there, it's stable, it's not moving, you can then begin to infuse your chemotherapy. Right. With that, I think, all right, so one more slide. So after chemotherapy, the ophthalmologist will then take the patient back a month later to do an EUA under general anesthesia. And you can see here, these are the large angry looking vessels supplying this big tumor. Post IAC, the tumor has shrunken quite a bit and you don't see that large vessels anymore. So with time, this will form a scar, and if it's stable, then it's a successful treatment. We do this IAC sometimes 3 times in a row, which is about a month apart, and it's then assessed to see how it has responded to the treatment. Right, going into my last case. So IR in rescue procedure. So in oncology, patients may come in with multitudes of problems. One of it is bleeding, and therefore IRs are always called in to stop bleeders. I present to you a 44-year-old female patient, para 2+1, last childbirth was 15 years ago. She was actually diagnosed with gestational choriocarcinoma with lung mets. She had a history of 2 evacuations. However, the HCG levels still remain high. She completed 5 cycles of methotrexate. Unfortunately, the levels still remained high and was then started on the second line of chemotherapy called Imaco. Unfortunately, she came in with excessive bleeding. I think within a week, she had bled 2 liters. HP dropped to 6, and she was then topped up to 10, and then dropped to 7, and requiring 6 units of packed cells. So, recurrent transfusions has its own risk, and therefore the patient was then referred to us for further management. We then proceeded to do an embolization of the uterine arteries to reduce the flow, and in hope that that will also reduce the tumor itself. So this is the catheter. Again, this was done transradially. So we punctured the radial artery over the left wrist, inserted a catheter, that means through the arm, through the chest, all the way down to the pelvis. And this is the run in her left common iliac artery. So this is left common iliac artery. This is the external iliac artery. This is the internal iliac artery. And you can see a faint tumor blush here. We then super selectively cannulated the uterine artery, and then you can see this tumor blush with large uterine artery and small tortuous vessels that are nourishing this tumor in the pelvis. We then went on to embolize the uterine arteries. Again, after embolizing the arteries, this is the image on the right side, as you can see here. Again, in the internal iliac artery, and you now see just very, very little sort of tumor blush in the pelvis. We repeated this procedure on the right side. Post-embolization on the right side also shows just very minimal tumor blush left. Be mindful that the uterine artery also supplies the cervix and the vagina, so try to avoid non-targeted embolization as much as possible. So she's gone back to the ward and I'm being told that there's very minimal PV staining now. So we're quite happy, not requiring any blood transfusion, and we're waiting to see what her beta HCl levels are. With that, I end my slides. Sorry if it's very long and presentation with multiple different arms of the IR procedures. There are a lot more that I haven't covered. Tumor ablation is another big field with multiple options and techniques there, which I haven't gone into, and pain management as well. But I think I'll stop here for interest of time. Also, I'd like to shamelessly advertise, if whatever you heard today interests you, the Malaysian Society of Interventional Radiology is having our annual meet at the end of this year. Please feel free to come and listen to what's new and what's latest in the field of interventional radiology. Thank you very much.
Thank you so much, Doc. As you say, I think you have given us quite a bit of insight into the entire kind of scope, if not the kind of breadth that's in interventional radiology line. And we can see there's a lot of kind of promise for oncology patients. A couple of questions, Doc, which I think some of our colleagues may be putting in as well. And right. I think one of the kind of big questions I think to ask, which a lot of people have kind of at least about two or three people have kind of asked these. Actually, how do we kind of factor in making like therapeutic decisions using interventional radiology? Like, how do we kind of bring interventional radiologists into the field when we kind of manage a cancer patient?
Right. So with as you said correctly, I mean, I think treatment options these days, especially for oncology, so for everything else as well, but especially with oncology, is a multi-prong approach. I mean, the surgeons have their role, the oncologists obviously have their role, pain management, anesthetists, and IR have their role. So with most decisions moving forward with treatment, cancer treatment, a multidisciplinary team is usually called upon to make decisions. Tumor boards where patients are then discussed and then decide on what best is the treatment options for the patient. So yeah, so it's not that, it's no man's an island, no team is an island, no discipline's an island anymore. I think as long as you put the patient's interest as paramount, a multidisciplinary team, see what different teams can bring to the table and move forward with the treatment plan.
Right. So, like, for example, because of course you get large tertiary centers like yourself when there's like, there's a good MDT kind of process in place. But for many of us who sometimes work in smaller hospitals where, even we want to be able to give options to our patients, is there a way or like a process that we can, kind of reach out to get a consult, get someone to see you in a clinic? Is that something which happens?
Yes. So not all, but we are definitely working towards it. So the IR clinic is present. We run IR clinics. It's just being honest, it's not fully developed yet, but definitely IR clinics are there. Patients are referred to us. I see a lot of veno-lymphatic malformations and stuff like that, where patients are directly referred to me for such cases. And if I feel that this case needs multi-pronged approach, need a consult from someone else, we will then put it up for discussion. I mean, if it's straightforward case, Chemoport, for example, or nephrostomies and stuff like that, I'm happy to deal with it. But if say it's a multi-pronged approach, you know that the patient requires the management of not just you, then definitely multidisciplinary approach is needed. Coming back to your first part where you mentioned, yes, you're sitting in a hospital or a clinic in a district somewhere, or in your facility, there isn't this buffet of disciplines. Yes, you can still refer to an IR clinic or any clinic, and they should be able to help you, then direct you in the manner that needs to be directed in the management of a patient.
Absolutely. So within the Ministry of Health itself, what are the centers in which we maybe can see IRs, or is the service available at this point in time? And perhaps some look into university centers, private centers as well.
Right. Well, actually, IR is nearly everywhere currently. So wherever there's a cath lab, there should be an IR. So currently up north, Penang has an interventional radiologist. Alostar has an interventional radiologist. It's government hospitals. KL, there's multitudes. GHKL, HTA, Sungai Buloh, Selayang. Going south in Johor, Sarawak, there's one. Sabah, there's one. I haven't even begin to explain tell you about the universities. Most universities have an intervention radiology unit there as well. Private centers, most of them actually do have intervention radiology, if not a resident, definitely a visiting intervention radiologist. Yeah.
Okay, good. Doc, there's a question of one of our colleagues who asks, Dr. Ganesh, you brought up the issue of pain management and how interventional radiology can play a role in that. Would you care to kind of elaborate a little bit on that?
Right. From my point of view, I don't do pain management, but so pain management again is a big topic by itself. Within the Society of Pain Management, there are the neurosurgeons, anesthetics, orthopedic surgeons, the IRs who have done musculoskeletal or pain intervention are quite proficient in dealing with pain management, either celiac blocks, facet joint injections, neurolysis, they do that stuff. So that's in Sungai Buloh Hospital. They do a lot of pain intervention.
Right. Doc, there's also another question, perhaps from a colleague who asks, is there a role for interventional radiology in active management of childhood cancer? How much of work are you doing in the field of childhood cancer now?
Right. So in childhood cancer, as it stands, so I mentioned retinoblastoma. So IAC is something that we routinely do. That's quite bread and butter. Chemoports, Hickman lines for leukemia patients. That's what we often do. That's a sort of bread and butter in my hospital. Moving forward, honestly, we haven't done it yet, but tumor ablation, TACE procedures have been done overseas. It's not mainstream yet. I can't tell you whether it's mainstream overseas. Yeah, this is referring to pediatrics, obviously, but it's coming. As I mentioned, interventional radiology is a field that is growing. It is new, the new kid on the block. So the challenge sometimes is getting the other disciplines to sort of embark in a procedure that may not be well established. Not forget Malaysia, even worldwide. So it's there, it's growing. It hasn't really reached our shores yet. Yeah.
Right. But as you can, and I think one of the things that you've been telling us today is how fast and quickly the field has been growing. There's just a lot of applications for which the specialty seems to be very useful for as well.
Yeah.
And I'm conscious of time as well, and perhaps we can take one more question. There's one more question, and ladies and gentlemen, of course, feel free to kind of leave your questions if you have any kind of burning unanswered queries, and Dr. Ganesh can kind of will be kind enough to kind of address them at a later date. We can put it back onto the recording, which is always, you know, kind of available in the Dockety app as well, and we'll put it onto the YouTube channel for the National Cancer Society subsequently after this session as well. Doc, there's just one more question which looks at, are there this is an interesting one. So are these procedures under interventional radiology, are they largely able to be done as outpatient, or do they need to be done in an inpatient setting? First kind of sub question. Second question, are these procedures reimbursable by insurance in current practice?
So, first part, if it's a pediatric patient, unlikely it will be done under sort of local anesthesia. But okay, so for the most parts of it, adult procedures, yes. Chemoports are done as daycare. Fistulas can be done as daycare. Varicose vein treatment can be done as daycare. Varicoceles can be done as daycare. It is reimbursed by insurance. Most procedures based on our MMA charge books, it is reimbursed by insurance for sure. Even moving forward, a couple of intervention radiologists have admitting rights in private hospitals. Government hospitals, unfortunately, we do not, IRs do not have a ward. We don't have wards, and therefore we can't admit ourselves. But we are moving towards more of a daycare or walk-in sort of system. More because our clinical colleagues have told us, like, look, we don't have beds. For example, prior to this, permanent catheters for dialysis patients, we would insist on admission, and the nephrologists have told us, listen, we're running out of beds. What we'll do is we'll get the blood sorted out. If the bloods are okay, patients okay, can they just walk in, do the procedure, and then assess and send them back if there's no issues. So yeah, to the question whether it's walk-in daycare, yes, definitely. And is it covered by insurance? Yes, it is.
Right. So, Doc, thank you very, very much. I think this has really been a very, I would say, graphic session.
Radiologists, we always look at graphics, black and white, though, black and white.
Absolutely. And it's been lovely to see, like, you know, you walked us through quite a bit of the different modalities, the different kind of possibilities, more so with interventional radiology, especially in the aspect of cancer treatment. As we kind of wrap up the session this morning, could I perhaps ask you to give a couple of like closing words, burning images that'll leave us in our minds as we close the session for today?
Well, first of all, I'd thank you so much for having me on. Need to get I think the awareness of intervention radiology is not as well established as the other fields in this country. We need to get it out. I think the fault may lie with us. The IR fraternity seems to be still very much like the radiologist sitting in dark black room. So we need to get it out and get the awareness out. So I'm very thankful that you given me this platform. It's a growing field. Whoever is interested, please come and join us. Something that I probably didn't add in the slides of the slides that I presented is, although it's minimally invasive, complications then can still occur. When you said put some images, I've probably got some images of some good complications, but that I'll save it for that later. So what I wanted to get to is sometimes we get patients coming down and then we say, do you know what procedure? I said, yeah, just going to put in a small tube, isn't it? And actually it would be for some intracranial embolization where she can end up with a stroke and the patient herself has no clue what we're doing. I hope the doctors upstairs know what we're doing, but yeah, so get awareness. Basically, I think most important is awareness among our colleagues as well as patients is paramount.
Right. So thank you so much, ladies and gentlemen. We've been privileged this morning to have with us Dr. Ganeshwara Lingam, pediatric and peripheral interventional radiologist and clinical radiologist at Hospital Kuala Lumpur and Hospital Tunku Azizah. And he has been speaking to us about the different kind of roles of interventional radiology in oncology. So thank you very much, Doctor. And happy Awal Muharram to those celebrating. And I'm hoping that you'll have a nice weekend. Thank you very much for joining us. And as always, we'll see you next month. Take care.
Thank you so much.